Welcome to CAEP Grand Rounds, everyone. I'm Anton Hellman, coming at you from EMC Studios in Toronto. Now, these rounds, they're special because it's a collaboration between CJEM and EM Cases. Thank you very much to Eddie Lang and Ian Steele and Paul Atkinson for inviting me to host and suggesting this collaboration. Now, the Just for Facts series is written by expert EM docs on a particular EM topic. CJEM encourages proposal for other topics in the series. People can contact CJEM directly or Paul Atkinson with your topic, 5 key questions, and propose expert for those topics. So we'll have a lot of ground to cover here. And the title of the rounds is Zooming Through the Best of CJEM's Just the Facts. So let's do just that. We're going to pack in a potpourri of clinical questions and brilliant answers to those questions on 5 topics. So what are the 5 topics? So we're going to cover MRSA tissue infections with Heather Murray, who to swab, when to treat, and why. We're going to cover airway management, lessons learned in the COVID era so far, oxygenation strategies and indications for intubation with George Kovacs. We're going to cover aortic dissection. We're going to ask, can we rule out aortic dissection clinically? Is there a role for D-dimer? And what are the best meds in the ED for aortic dissection? This will be with Rob Ole. How to recognize and manage DKA with Justin Yan. And last but very not least, TIA risk stratification, how to do it well in the post-ABCD2 era, and some stuff on dual antiplatelet therapy, if we have time, with Jeff Perry. So we have about 10 minutes on each of the 5 topics, so this will clip along quickly. I'll discuss a few points with each of the speakers, and then we'll choose one question from the audience at the end of each topic. But before we get into it, I just got to show this slide, which is just that I don't have any interest to declare. And I have to say that the Scientific Planning Committee has reviewed and declared conflicts of interest for all the speakers. There are no conflicts, perceived or real, that have been identified, and there's been no external support received for this webinar. Yay. All right. So let's start with Dr. Murray. And these kind of questions always come up when it comes to MRSA infection. Welcome, Heather. How you doing?
I'm good, thanks. Thanks for inviting me in.
Fabulous. So now, before we get into the practice-changing questions on MRSA and soft tissue infections, can you give us first a sense of why MRSA is important? Like, why should we care if a skin abscess is caused by MRSA in the first place? If we miss it, or we don't treat for it, does it really matter?
So I think it's a great question. And I think the reason that we should care why an abscess is caused by MRSA is because patients care. I think people want to know if they have abscesses that are caused by MRSA for a bunch of different reasons. One, because they spread between close contacts. They cause small localized outbreaks between family members, people living in close settings, sports teams. So this stuff spreads around. And so it's important for people to know that they have it. It's important for them to understand how to prevent it from spreading to people who are close to them. And I think sometimes patients will have recurrent or multiple infections, and there may be a role for decontaminating them, for decolonizing, using bleach baths, chlorhexidine showers, that kind of thing. So there's things that can be done when people have recurrent abscesses. MRSA is an organism that does tend to crop up again and again. I think there's important for people to know so that it doesn't, so that people understand the spread and they can take appropriate precautions. And then finally, I think it's just important to understand the local prevalence in your area. I think that understanding how much MRSA is out there, how much drug-resistant bacteria is around, is a really important thing for us in terms of how to manage infections in general and how to control our antibiotic footprints.
Absolutely. The other question always comes up. So let's say that you performed a meticulous IND for an obvious skin abscess in the ED. You've gotten rid of all those loculations. Maybe you've irrigated the cavity. There's always a bunch of questions that come up once you've done that, in my mind at least. So the first one is, which patients should have a swab sent for CNS for MRSA, if any?
Well, before MRSA became a frequent cause of soft tissue abscess. We didn't culture abscesses because it didn't tell us anything useful. And now I actually believe we should be culturing all of the abscesses that we drain for a couple of different reasons. One, because every community has a different prevalence of MRSA. So the MRSA in Kingston is not the same as the MRSA in Perth, in Toronto, in Kelowna, in Calgary. Like, these cities all have different prevalences and different resistance profiles. The clindamycin resistance rate, which is the thing that is increasing the most in terms of MRSA antibiotics, is different across all centers. And you can't understand what the bacteria are doing in your organization unless you have a well-populated antibiogram. And secondly, I think we should culture everybody, because I think people want to know. This is what I said in the first place. I think it's important to institute contact precautions and recognize the interventions that people can do if they have an MRSA infection. So I guess I would say the antibiogram, the resistance profiles in your center is populated with these cultures. And if we can populate those antibiograms appropriately, we can understand the prevalence in our communities and practice better medicine.
I mean, absolutely. From a public health perspective, that totally makes sense. What's your opinion in terms of, I mean, the problem that I have is that here we are swabbing every single person with an abscess. We see lots of it. There's, do you think there might be resource issues there? I mean, how much does a swab cost, for example?
Yeah, so the swab cost is a little bit variable from center to center. I've been quoted anywhere between $60 to $90 for a swab, so it isn't a cheap thing. But I suppose that I would come back to you and say, otherwise we're spraying unnecessary antibiotics. And I got kind of concerned about this practice, because when the big clinical trials came out a couple of years ago that showed an increase in cure rates with the addition of Septra or clindamycin, all of our residents and faculty started with this equation that was like abscess equals IND plus antibiotics, right? Like, everybody was getting Septra indiscriminately. And I think that the cost of those side effects that we are causing with unnecessary antibiotic use, and the unmeasurable cost of the rise of community resistance, the more antibiotics we prescribe, the more community resistance there is. That's a well-known association. And so we need to control our antibiotic footprint. We need to understand our local antibiotic population. And I think we need to very much control and restrict antibiotic use to very targeted people within the abscess population. And so I suppose I would say, if your organization is unhappy with the culturing routinely, you could do a targeted or sample culture arrangement, but I haven't seen any organization interested in doing that. And right now, all the microbiologists are a bit distracted by COVID.
Right. Great. That's a great argument, actually. Even just the antibiotic side effects, especially for something like Septra, with hyper K and renal failure and really life-threatening, not to mention Stephen Johnson's, for example. All right. So that's a bit about who to swab. I mean, certainly if we're going to be referring someone to an infectious disease specialist, for sure we're going to swab, but I think the audience will kind of make up their minds based on your argument there. It's a pretty good argument to actually swab. Next question that always comes up is which patients should be treated on spec for MRSA? So if you're going to treat a cellulitis and or abscess, usually we'll use cephalexin, something like that. When should we be switching to the MRSA, the antibiotics that cover MRSA?
So I don't think that we should be treating uncomplicated cellulitis with anti-MRSA antibiotics. There is no evidence that there is benefit. And most MRSA is caused by Strep pyogenes, and it's not an MRSA problem. It's not a Staph aureus issue. Purulent cellulitis is the exception to that. So if you have a wound infection with purulent drainage, or you have a purulent cellulitis where there's purulent foci, that is more likely to be a staphylococcal infection and would benefit from being cultured. I think that actually,
Heather, that actually brings up the idea that we know that we're actually not great at identifying abscesses when we just look at someone who has cellulitis, and that POCUS definitely increases our hit rate of actually identifying an abscess. So that definitely comes into play when we're talking about cellulitis versus abscess. Use your POCUS if you're not sure if there's an abscess or not. Sorry, go on. You were saying about treating on spec.
Yeah, no, 100% endorse the routine use of POCUS and getting good at POCUS for skin and soft tissue infections and for identifying abscesses. I think the people that I would consider immediate therapy in are people who have multiple separate lesions. Those tend to be more likely to be MRSA related. Patients who have a previous MRSA infection and come with a new abscess. So they tell you, I had one, a few months ago, and now I have another one, and it's weird that I'm getting these abscesses. Those people are more likely to be MRSA. And especially if the previous one was cultured and showed MRSA. And then finally, the people that I would consider treating immediately are people with follow-up challenges, patients with addiction problems, vulnerably housed, and who you can't get hold of. Those people I would probably, and have risk factors. They live in close quarters, they use intravenous drugs. All of those patients I would probably treat on spec. But again, it's better to culture and phone, and then you can target your antibiotic therapy exactly to what the resistance profile is.
Yeah, that makes sense. Absolutely. Now, what antibiotic are you going to use if you are going to treat for MRSA? So there's Clinda, and I always worry about things like C. diff with Clinda. There's Septra, as you mentioned, and again, I always worry about renal failure and hyper-K on people, especially on people with ACE inhibitors. And then there's actually doxycycline, which is nice because in the Lyme seasons it covers Lyme as well, because sometimes that's hard to pick up as well. So, what is your antibiotic choice for treating MRSA?
So I've been avoiding clindamycin. I think clindamycin resistance is increasing across the country. The pooled resistance in Canada is about 40%. So that's an evolving problem. And there's a 20% rate of diarrhea. So clindamycin, not a great choice, but sometimes that's what you're left with if there's allergies and so forth. Septra is my go-to agent unless people are on an ACE inhibitor or an ARB because of the hyper-K interaction. And doxycycline is also a good choice. It wasn't used in any of those clinical trials, but most of the MRSA has a high sensitivity to it. And then linezolid is another more expensive oral agent that is not widely available, but you could use that as well. Okay,
so you got 4 choices there. Sounds like Septra, maybe Doxy, and if you're rich, you've got some other choices. All right, let's open.
Yes, Doxy.
Thanks so much. So let's open to an audience question. Dr. Lang, Dr. Atkinson, do we have an audience question there?
Yeah, thanks, Anton. We do actually have a question. So Heather, the question from across Canada, the question of the moment is, do we need to pack abscesses, especially ones that are suspected to be MRSA abscesses, with some form of antibacterial gauze after drainage?
So
and that's what I can say. That comes from Greg in Alberta.
Okay. I would say that the quick answer to that is there's no evidence that packing abscesses after IND improves any kind of outcome. And it probably just increases pain for patients. So I think by all means, freeze it properly and really get it properly drained, because the cure rate for abscesses is 70% with nothing but IND, even if they're MRSA. So a well-drained abscess drainage, proper organic steel sort of intervention with no drugs is going to have a 70% cure rate. So by all means, good IND technique, but no need to pack unless you sort of have a particular attachment to it. There's no evidence it improves outcomes. Beautiful.
Thanks so much, Dr. Murray. That's pretty much everything you got to know in like 5 minutes right there about MRSA. We're going to move on to aortic dissection. And we have with us Dr. Rob Ole. And he is is it from North Bay, Rob, or Sudbury? I always get mixed up.
Beautiful northern Sudbury.
Beautiful Sudbury. Excellent.
Yeah.
Okay. And I'm sure you see your fair share of aortic dissections up there. Now, we all know that aortic dissection is a tough diagnosis, and its misdiagnosis rate is actually insanely high. Like 38% of cases are missed. At least that's what the literature says. how can we improve our clinical assessment so that we don't miss this elusive diagnosis so often? In other words, what should we be asking for on history and doing on physical to minimize our chances of missing this brutal disease?
Yeah, and that's the core of reducing your miss rate of aortic dissection, is really drilling down into the three biggest areas in your clinical assessment. So one is your physical exam, two is your high-risk historical risk factors, and then three is your pain. So for the physical exam wise, you want to make sure that you're assessing for any focal neurological deficits, assessing for a pulse deficit, assessing for a new murmur of aortic insufficiency, or really hypotension. I like a word on pulse deficit. So the pulse deficit, it's a proximal pulse deficit. So we're talking femoral, brachial, carotid. We see a lot of people with peripheral vascular disease. So it's common that you have a pedal pulse, which is absent. That's not a pulse deficit. The second area is the risk factors, the historical risk factors. And they're the ones which were commonly taught as connective tissue disease, aortic valve disease, recent aortic manipulation, a family history of aortic dissection, or a known aortic aneurysm. The thing to note about that, and we've heard this in different podcasts, especially on EM cases and talks that David Kerr has done, is that the connective tissue diseases, so half of all those who have one, they're undiagnosed into their 20s, and a quarter of them get it into their 40s, and they don't know they have a connective tissue disease. So you got to look at the patient in front of you and see if they have any features of Marfan's or Ehlers-Danlos. The last area, and the most important, is the pain. Because most patients we see, they're going to have a normal physical exam, and they're going to have no historical risk factors. So we're risk stratifying them mostly on their pain. And the big areas or big things you're looking for there is whether the pain is severe, whether it is abrupt in onset, whether that pain is tearing or ripping, or whether it's migraine.
Yeah, Rob, I remember there was that study way back that said, just like you learn in medical school, if you just ask about the onset of the pain and the quality of the pain, then, you're probably going to get that abrupt onset of severe pain, and the quality of pain, it's either tearing or sharp or ripping. I think a lot of this in the history comes back to just those very basic things that we learned in medical school, right?
Yeah, it's beautiful. You can get a lot of the way in regards to risk stratifying your patients by really listening to what they're saying, and that's the greatest thing,
All right, great. So that's a bit about the history and physical and the doing a clinical assessment. I guess it's just, you got to have that cognitive forcing strategy always in the back of your mind that any patient who comes in with chest pain or neurologic symptoms could have an aortic dissection. Now, there's an interesting bit in your Just the Facts article where you explain that a good clinical assessment without CT can actually lower the risk of aortic dissection to less than 1%. So I think it was 0.7% in the article, which is generally, considered below the threshold, which the harm for the testing may outweigh the harm for missing the diagnosis. So then the question becomes, well, which patients then do require a CT to rule out a dissection?
Yeah, and there are varying degrees of association with all the different signs and symptoms that I mentioned there. By and large, your physical exam findings are your high risk ones. They're not common, but when they are there, they really push you towards following up on aortic dissection, so for a CT. So those are the pulse deficit, neurodeficit, new murmur of aortic insufficiency, or the hypotensive patient, and you've got no other reason for these symptoms. The other ones would be if you have somebody who's got a known aortic aneurysm, there's really nothing that you can do on history and physical, which is going to reduce the probability that that patient has or doesn't have an aortic dissection or a rupture or a leak. And then the last one is the patient who's got multiple high-risk pain features. So it's your patient who's got severe, abrupt, ripping chest pain. I don't need to tell you that that patient's high risk and should go straight to the CT.
Sure. All right. I'm going to talk about a very controversial topic. And Rob, I think last year at the CAEP conference, after a couple of beers, we had a very heated debate that was wonderful, actually. Some docs are using D-dimer to help risk stratify patients with suspected aortic dissection. Unfortunately, the numbers aren't quite as good as we've seen, say, with PE in terms of safely ruling out the diagnosis. When I dove into the literature on D-dimer and aortic dissection with Justin Morgenstern and Rory Spiegel in EM cases, we were all convinced that there really is no role for D-dimer in the workup for such a rare disease of aortic dissection, which is very hard to study for that exact reason. So I understand that your opinion is a bit different. What is your opinion in terms of the role of D-dimer for the workup of aortic dissection?
Yeah, I think there is a role. I think that there's a couple of important features when we think about D-dimer. I mean, number one, it's in context of your history and your physical exam. I think number two, the diagnostic accuracy of D-dimer, I mean, it's as good as any of the other signs or symptoms we're using on a routine basis to guide our workup. It's another data point, but it's got to be taken in context of the clinical exam. And so the important things is that you can't use it in high-risk patients. When we talked about the high-risk features, which would push you towards CT, so those aren't the patients which you should be using in D-dimer. There was a cool study out of Italy by a fellow Nazarian in 2017, and they looked at, amongst other things, the accuracy of D-dimer in ruling out aortic dissection. So out of the 240 patients included, there was 8 of those that had a negative D-dimer. So they were missed if they'd used D-dimer. But when you drill into the clinical characteristics of those patients, 3 of them were people coming in with severe abrupt onset ripping chest pain. You're not going to be getting D-dimer in those. And 3 of them had high-risk physical exam findings, and 1 of them had a known aortic aneurysm. So you can't use D-dimer in high-risk people. It's the same as PE. And the flip side of that is you don't use it in low-risk people. So if you've got no high-risk pain features, if you've got no high-risk historical risk factors, and if you've got no physical exam findings, then that person's low risk. You're done. You don't need to use the D-dimer. So then the question is, who can you use it in, or who is it potentially useful in? And really, I think it's in those people that have 1 or 2 high-risk pain features, which we may see. So the person with severe chest pain, and you've got no other reason for it. Now, you've got a couple of options if you run into that patient. Now, and that what you do is it's dependent on how you practice, what skills you have, and where you work. You can send them for CT, you can get a D-dimer, or you can potentially reach for your ultrasound probe. If you're working in a rural setting and you don't have access to CT, and to send someone for CT means you're losing one of your nurses, you're losing a local rig, then that might be a great setting to actually use D-dimer. And if you're in downtown, wherever, and you can get a CT like this, then you have an option. You can get a CT, D-dimer, or point-of-care ultrasound. So whether you use it or not, it depends who you are and where you practice. But I think it is another data point, another tool in your arsenal to try and prevent you from missing the diagnosis.
All right, we'll continue the debate next year at CAEP. Hopefully we can do it in person when it comes to D-dimer. Okay, one last question we're going to fit in here is just, we've talked about the workup. What about the treatment of aortic dissection? Now, my understanding is that really you want to treat the pain first, then the heart rate, then the blood pressure. So what are kind of the biggest pitfalls in terms of the treatment of aortic dissection in the ED?
Yeah, you hit the nail on the head, Anton. Like the biggest thing is treating the symptoms first. That pain is going to raise up your sympathetic surge, and you're trying to push that down, control your heart rate and your blood pressure with your beta blockers. But if you don't treat that pain, it's going to take you longer to actually get to your target heart rate and blood pressure. And when you do get there, if you decide to turn your attention to the pain, you get rid of that sympathetic drive, your blood pressure is going to drop. And that's the biggest one. I think the second one is thinking someone's hypotensive when they're not actually hypotensive. So if you are starting to treat somebody, it's important that you check blood pressures in both arms. What you might see is the dissection flap showing you an artificially low blood pressure in one arm, but what the flap sees is your highest blood pressure. So if you have a higher one in your right than your left, you're targeting your right. And then following along from that, if you've got somebody who's got equal blood pressures, and then all of a sudden they tank their blood pressure, you got to check both arms, because what might have happened is that flap may have actually just propagated and impaired blood flow to your arms. So you might be artificially worried about a tank in blood pressure there if you're not aware of that.
Awesome. Well, thanks so much, Rob. I got to say, for sure, everyone's going to agree that you have the coolest accent of everyone on the show tonight. All right. We're going to open it up for a question from the audience. Dr. Atkinson, do we have an aortic dissection question? Good hot one.
We have 4 questions, so I'll try and actually do a combination, and I won't take offense at the accent comment at all. So I can do a fake Southern one, but anyway. So the background, Rob, from the combined question here, or 5 we've got actually, is knowing that it's a rare disease, right? It's already less than maybe 1 in 1,000, maybe 1 in 10,000 of chest pain presentations. Knowing that, well, what percentage have no pain? Is getting this sort of score of less than 1% useful at all? And do we need to start actually having a formalized risk score if we're going to actually go prime time with that approach? Combo question.
So yeah, it's difficult. I mean, the question is whether we can standardize the diagnostic workup, whether people have a good sense of who those moderate risk people are. And the problem about generating an evidence-based score is that it's a bugger of a disease to study. You need a lot of centers over a period of time to actually get enough cases to generate rules the way we have done in the past with the TAA score, with the CT head. And so our best approach was with the guidelines that we put out, was really gather all that evidence together and try and assess what signs or symptoms would push you above a threshold to image, what symptoms would push you below the threshold for I don't need anything, and then you end up with everybody in between, and then there's potentially a role for D-dimer. So there is an option for a way of augmenting your clinical gestalt with the Canadian guidelines that were recently published.
Amazing. Great. We are on now to, thank you very much, Rob. We are on now to airway. We are going to be talking with George Kovacs, and we're going to be talking with George Kovacs about lessons learned from COVID in terms of airway out from Halifax. Great to see you, George. How you doing?
Great to be here. Thanks, Anton.
All right. So what we're going to do is we're going to start with 2 specific questions, and then we'll get into more of this sort of general lessons learned. Because there's 2 specific questions I find that always come up. The first one is about oxygenation strategies. So, we worry about aerosolization of coronavirus because, we think that with some of these tools, there's aerosolization of the virus, which can be very contagious. What is the best oxygenation strategy, assuming that aerosolization is an issue for the ED patient that are suspected of having COVID pneumonia?
Yeah, so easy question to answer in the allotted time, but and there's certainly a lot of controversy around this. So I'll premise the fact that, again, it's an emerging literature, which is a progression from where it was in terms of it just being a lot of experience with learn on the fly scenario. But I think that the way I look at it is essentially from an oxygenation point of view, you're thinking of 3 things. You're thinking about escalation of oxygenation. And then once you've made a decision, you're thinking about pre-oxygenation. And then lastly, you're thinking about when things don't go well, about re-oxygenation. So I'll focus in on the first one. But and again, if you look at guidelines, they're very non-committal in terms of flows and et cetera. But we have to remember that even though we're worried appropriately about aerosolization, it is a disease that is essentially one based on droplet and contact spread. And so if somebody comes in and they're either suspected COVID or identified as such, and they require oxygen, what happens in our institution is they get supplemental oxygen in a simple way, which is using conventional nasal prongs. Now, the 6-liter thing has come up here and there. And the only thing I'd pay attention to 6 liters is to say that really if you need to deliver more of an FiO2, then nasal prong's not what you should do, right? And up to about 6 liters, if you look at the aerosolization that happens, it's pretty equivalent to tidal breathing. Now you can take away that by what's being suggested by placing masks over the patient, right? If they don't need oxygen, and then once they need oxygen, placing a mask over that. So we'll go for 6 liters of nasal prongs. You're recognizing if their oxygen requirements are increasing, that you have a potentially sicker patient, and we'll escalate then to a non-rebreather, and we still are doing that in a droplet contact environment to 15 liters. And what's nice about a proper non-rebreather, again, is it acts as an intrinsic mask in terms of disbursement of anything that is going to be aerosolized. So we'll go from 6 liters to 15 liters, again, in a contact scenario, but you have to be on alert that this patient's getting sicker, and you're probably going to have to move that patient. If you're concerned, what you do is you put a mask over it. And I have an image that I may or may not show where it's been demonstrated this dramatically decreases the aerosolization. And the higher the flow, the more effective that those masks are, because the dispersion is at sort of at a higher rate. Now, once this happens, and you're at 15 liters, they're requiring that, then again, you're on alert that you have a sick patient. You should move them to a proper area so that you can escalate. And this is where, the question comes, what are we escalating to? You can either escalate to mechanical ventilation, or you're going to escalate to some non-invasive approach. And our guidelines as of April 30th, I think, have been validated by emerging evidence. And what we're seeing in many places, the use of non-invasive techniques, in particular, the use of humidified high flow nasal oxygen. And once you make that transition, you're going to a room where you're going to be, again, everybody's going to be in an appropriate AGP, appropriate PPE, and that should be a room that if you need to escalate to intubation, you can manage that patient in that room. So,
yeah, I think a lot of challenges, George, have been that a lot of hospitals have made high flow difficult to access in the emergency departments. I know that at the hospital I work, that was an issue for a while. Now they finally do allow high flow in certain rooms in the emergency department. But I think, high flow seems to definitely have promise to try and stave off the need for intubation in those COVID patients.
Yeah, no, I mean, again, what we're getting back to is that this is a disease that we thought was so different than any other disease. And what's happening over time is that we should be treating this more as a disease that we've been managing all along. Patients with acute hypoxemic respiratory failure, and we should employ appropriate techniques for that patient group in the appropriate environment, wearing appropriate PPE. And we're thinking of this strange beast that's entirely different. And what we're realizing along the way is that it's very, very, very similar. So we're using all the same tools. The only thing that we're doing differently that we might employ on other patients we hadn't tried before is, as a mode of augmenting our oxygenation, is that we're going to do awake proning during that early period. But otherwise, that's what I think we should be moving to, because we're moving away, and people are pleading to avoid early intubation, and they're misinterpreting the early literature that was giving guidance for doing that.
Yeah, that leads to my next question, because, at the beginning of COVID, we were all gung-ho about intubating everyone. And we quickly realized that we should try and avoid intubation really at all costs with these COVID patients. That then brings up the question of, what are the indications for intubation for someone that is highly suspected of COVID pneumonia? Now, sometimes we see the patients that could be a bacterial pneumonia, but there's definitely that subcategory of pneumonia patients where we're like, this is definitely COVID. What are the indications for a tube down the trachea any different for a patient with bacterial pneumonia, let's say, versus the patient highly suspected or confirmed COVID pneumonia?
Yeah, well, I think the simple answer that I'm going to give you here is no, with a few caveats. that early intubation stuff was based on what was happening in China, where they were very concerned that they're going to have multiple patients arriving requiring mechanical ventilation at the same time. So to avoid these patients who are going to eventually have cardiac arrest, let's intubate these patients early. And that got sort of misinterpreted. And then there was some stuff about certain flow rates that were at risk. But that's where I think we went off, and then we've been experimenting with more conservative approaches. So the answer to that question, if you want to, the answer to that question is what I do is I calculate a PF ratio, and if it's 199 or less, or I do a ROX index and it's 4.88 or less, and I do a CT scan, and the estimated lung weight is less than 42 grams per whatever, then I mix that up in a jar, right? And then I look in it and I say, oh, okay, I have to intubate based on what I see there. So I'm being facetious here, obviously, but there's a lot of stuff out there, again, for us to sort of quantify this. But if you look at something like the ROX score, which I kind of like, because what it does is it looks at your saturations, your FiO2, and your respiratory rate. And if you plug it into when this would be a failed high flow scenario, well, it's for patients that have a saturation under 90%, requiring an FiO2 of over 90, and have a respiratory rate of greater than 30. What's that mean? Oh, that's a sick patient. So these are the patients that you need to get ready to intubate. And these are patients that you're not going to give a trial for a conservative approach. If they present early and you go through your escalation of oxygenation, you have the potential of doing that and giving them a conservative approach. But patients that present at that stage, particularly if they're altered or on vasopressors, these are patients that you need to prepare and intubate them in a protected manner. So I don't think we need to get too complex about it. You look at them with the lens of the way you've made the decision before. It's clinical judgment.
All right, George, and in a couple of minutes here, what other lessons can you tell us that we've learned in the COVID era in terms of airway?
So I wouldn't mind putting up one slide here, and if I can share my screen.
All right, we can make that happen.
And can you see that?
Beautiful.
Okay, so I'm just gonna put up this this one pic here that you see in the center of your screen. And what I think we need to remember, this is a pic in our department that I've cartoonized so we can't see the details of the people here, but they're real cases. And this is old-fashioned laryngoscopy and intubation, and the one on the right is a COVID protected airway. What we need to do, I think, in this setting is we do need to slow down. We need to slow down in terms of our decision to intubate. We need to slow down before we go in the room and make sure we're prepared to do it. We need to slow down when we exit the room. This is by far the greatest risk, right? People are high-fiving. We got the tube, with all this hot stuff on, wearing all this gear, and a sick patient. And then they're getting complacent in the way they take off the gear. And that's the biggest risk for people. So you need to slow down. You need to be better than good. And this is important because, what this COVID has exposed a few things. But we need to, for a patient safety point of view, we need to make sure we're good at the skills that are required. Our team is good, and that we can prove that we are good. Right? In terms of having data saying, how are we doing in terms of complications and success? Because other departments are coming around and asking questions about, I hear you're good, but show me that you're good. So we need to simulate, we need to practice together and make sure that we're good with these skills. And the last thing is that we need to turn, crisis into opportunity. There are all kinds of legacy issues that have come out of COVID, right? An example here locally is that, we have a great collaboration. The guidelines were written by emergency medicine, critical care, and anesthesia, right? We have a group that goes out and trains the departments all around the province. We've created resources. We've increased the access to video laryngoscopy. We've exposed gaps in our system. So we need to turn, the crisis into opportunity so that we can bring these things forward and have a legacy beyond what we're experiencing here. I just want to finish with this last thing, is that so we can all do what we, you can all wear the t-shirt. This is David Lewis, who's an award winner with CAEP from St. John, New Brunswick. And I'll talk about this at the very end of it. These are a t-shirt that I've been sending out. We're emergency physicians and we resuscitate. We do all kinds of other things, and it's a real challenge to maintain these skills, but we need to do it for patient safety, for the safety of ourselves and our team.
Well said, George. Thanks so much, man. I hope this COVID thing ends soon, because I haven't seen you in a long time and I want to see you soon. So we're going to move on now to Justin Yan from London. And we're going to talk about DKA. So let's get the slide up here. These are some of the things we're going to talk about. Justin, welcome to the Grand Rounds.
Thanks so much, Anton. It's great to be here.
All right. So the first question I have is with diagnostic pitfalls. So the diagnosis of DKA can usually be made when the serum pH and the bicarb are low with an anion gap. Serum or urine ketones are positive and the patient's hyperglycemic, but we've all heard of euglycemic DKA. So we know that patients can have DKA with a normal serum glucose, but what about pH? Why is it important to consider the diagnosis of DKA in patients with a normal pH?
That's a really, really good point, Anton. As you say, it really adds to the diagnostic pitfall of DKA, because you think classically, somebody who has diabetes, they're going to have a high glucose, positive ketones, and acidosis. And you're absolutely right again that I think clinicians are becoming increasingly aware that patients with DKA can be euglycemic. And that's increasing in prevalence due to use of SGLT2 inhibitors in patients with diabetes as an oral agent. We're also seeing it less commonly in patients who are pregnant and those with alcohol use and those who are food restricted as well. But as you pointed out, to make things even more complicated, patients with DKA can have a normal or near normal pH as well. If patients are vomiting or if they're dehydrated to an extent, either as a precipitant or result of DKA, they can present with a simultaneous metabolic alkalosis from their hydrogen ion loss or volume contraction. On top of that, as you all know, many patients with DKA will compensate for the metabolic acidosis with a respiratory alkalosis, which can confuse the interpretation of blood gases even more. On top of that, in patients who are in extremis, there can also ultimately be a respiratory acidosis if their compensatory mechanisms begin to fail. So DKA is really one of those disease entities that can present with any combination of acid-base disorders. You can get respiratory or metabolic acidosis or alkalosis, all in combination, along with things like ASA toxicity, for instance. So putting all of it together and knowing all this, we really should avoid ruling out DKA, not only simply due to a normal blood glucose, but also because if there's a normal or near normal blood gas as well. DKA patients can have a normal pH due to their underlying precipitant, which contributes to that mixed acid-base picture. And so the bottom line for me is that we as clinicians should really just have a high clinical suspicion for DKA in any patients with diabetes, and a really low threshold for keeping it on the differential diagnosis.
Yeah, absolutely. I mean, if we all had beta hydroxybutyrate, that would make things easier, but at least, just think about getting ketones in patients that present with belly pain and vomiting. You're not sure what's going on for sure. So that's
present in any way. So that's great.
Yeah. Yeah. So that's a bit about picking the diagnosis up. Let's talk a little bit about treatment. So one controversial part of treatment of the severely acidotic patient is when, if ever, to give bicarb. Now, it makes us feel better to watch the numbers improve when we give bicarb, but we don't have any really great evidence that it improves patient outcomes. In patients with DKA in particular, Why is giving bicarb so controversial, and when should we pull the trigger and actually give bicarb, do you think?
Yeah, as you mentioned, we see someone with a low pH, and it's completely natural to feel tempted to treat that number with the sodium bicarb. But depending on the source you refer to, there's even a lack of consensus about what that number is that people should pull the trigger in terms of administering bicarb. So that's something, a whole other discussion in itself. The idea of giving bicarb to someone who has DKA does have its theoretical advantages, but as you say, it doesn't really translate to patient outcomes. Theoretically, if you're going to treat a severe acidosis, you can treat hyperkalemia or severe hyperkalemia with bicarb, and also replace direct bicarb losses from the GI tract or renal losses as well. So this might be beneficial in other causes of acidosis, but for DKA, it's much more important to treat the underlying pathophysiology of DKA with aggressive fluid resuscitation as well as insulin. Most of the evidence against treating DKA with bicarb comes from a systematic review that was published in 2011 in the Annals of Intensive Care. And what they did in this systematic review was they summarized 44 studies, including 3 RCTs on bicarb administration in DKA. The authors admit that there was a lot of heterogeneity with respect to what pH threshold the studies used, what concentration of bicarb they used, the timing of administration, as well as the amount used. And bottom line for their systematic review was that there was, in a couple of the RCTs, a very transient improvement in the acidosis within a 2-hour period, but it wasn't sustained, and there was no improvement in any kind of patient-important clinical outcome. In fact, there's actually some retrospective evidence of actually worsening ketosis and hypokalemia, as well as in pediatric patients, some evidence of cerebral edema and prolonged hospital length of stay. So based on this systematic review and expert consensus, bicarb isn't routinely recommended in any DKA protocol that I'm aware of. Currently, I think experts are essentially suggesting it might be considered if acidemia is very severe, definitely not if pH is anywhere around 7 or greater. There may be some help to administering bicarb prior to intubation to attenuate the transient CO2 rise when you're inducing the patient and paralyzing the patient. But the bottom line for us as clinicians is that we should really think long and hard about its use, if at all, and consider the individual specific characteristics and understand why we're using it, if we are at all.
Yeah, absolutely. I mean, I know for me, for DKA, the only time I would use it is that last thing that you said was if the patient's really acidotic and I need to intubate them, that can be a clean kill if you don't help them along a little bit. And I'm willing to use bicarb in that situation for sure. Now, let's just go a little bit more general here. So the care of DKA patients in Canada is pretty good, even though, as we've been talking, it's very tough to pick up. And there's some controversies in treatment as well. What do you think how do you think that the care of patients with DKA can be improved in Canada? We all have protocols for DKA, or at least we should. And if there's going to be one diagnosis that would benefit from a protocol, I would think it would be DKA. That's, I guess, a little bit of a hint of what you might say in your answer, but how do you think we can improve DKA care in Canada?
You're totally right, Anton. And I think there's some pretty good evidence out there that standardized protocols can help optimize patient care for various disease presentations in the ED. If they're developed properly and based on good science, and I will emphasize that if it's based on good science, then they do have the potential to reduce variability in care. They can enhance workflow and improve coordination of care and change practice through evidence-based care as well. For DKA specifically, it's actually interesting that you mentioned that, because I'm actually doing a project right now with a couple medical students from Western, where we're collecting DKA management protocols from EDs across the country. And we've gotten, I think, just a little over 50 responses right now. We're in the process of comparing and contrasting the protocols in the upcoming weeks. And what's really interesting to me, just with a preliminary look, is that there's likely a lot more variability than one might expect. And there are even some large centers in our country who don't have any kind of DKA protocol at all. So we're hoping to be able to present our findings in abstract form at CAEP 2021. So stay tuned on all of that. The last point I'm just going to make about protocols is that Diabetes Canada does have a DKA guideline that is openly accessible on their website and can be used as a starting point. One small caveat about it, though, is that the guideline was developed by endocrinologists without really any kind of emergency medicine input. So it has a little bit of a different approach than what might be completely useful for our purposes as ED physicians. We, as a study group, actually published a survey in the Canadian Journal of Diabetes a few years ago, which demonstrated that a lot of ED physicians were completely unaware that any kind of guidelines like this existed. And there was a lot of variability in practice patterns, as we're discussing, specifically with respect to fluid and insulin administration. So there's a lot of room to improve care and knowledge translate for this patient population.
Absolutely. All right. Thanks so much. Those were some great insights about DKA. We're going to save the audience question until the end. We're going to go on to Dr. Perry now and talk about TIA risk stratification. So when it comes to TIA, if we can get the diagnosis right, it's sometimes hard to figure out which patients are, how we can best risk stratify them, what kind of imaging patients need, which kind of imaging patients need, and what kind of treatment they need. There's actually a lot that's quite new on this. So, Dr. Perry, let's start off with risk stratification. So the death of the ABCD2 score is kind of old news by now. It's neither sensitive nor specific. And as you discovered in your excellent paper from a couple years back, it misclassifies about 10% of patients as low risk. That leaves us with the big question of how to risk stratify patients with TIA in the emergency department. Now, there's a huge range of presentations of TIA, from some vague paresthesias for a few minutes to vertigo to dense hemiparesis for an hour. So, Dr. Perry, how do we best risk stratify TIA patients in the ED?
Yeah, so thanks, Anton. So first off, it is extremely important that we manage TIA patients, especially high-risk TIA patients, quickly. Prior to the year 2000, the subsequent stroke rate at 90 days in North America was about 7.5 to 10.5%. More very recent systematic review has shown that this has now dropped to a 90-day subsequent event rate of just under 4%. And some studies where optimal management is done, it can drop down to just over 1% on 9-day stroke rate. So early treatment is effective. Problem is that TIA and query TIA or possible TIA is common. And so most centers, and certainly in Canada, cannot accommodate or manage all these patients maximally all from the get-go, and it's inefficient to do so, quite frankly, because many of these people don't need it. So trying to figure out who's high risk, who's low risk is very important, so that we can manage the high-risk patients quickly, while the low-risk patients can be managed in a much more conservative fashion. So how do we figure out who's high risk? Well, this is difficult. It's starting to get clearer. Excuse me.
I hope that's not a COVID cough.
My COVID. That's it. Who's on call tomorrow? No. So basically, the ABCD2 has underperformed. The ABCD2I is a little bit better. It includes 3 points for having an infarct, either chronic or acute, on your imaging. It performs a little bit better, but still not great. So we have developed the Canadian TIA score. We previously prospectively derived this, published it in Stroke in 2014. And this entails 13 variables, so not straightforward. But they are clinically intuitive and available variables. And they come from either history, physical exam, or investigations you'd routinely do in the emerge. And we have recently validated this in a cohort of over 7,000 patients, and we've presented this at CAEP and CJEM. However, it hasn't been fully published in manuscript form yet. So you will have to stay tuned before you can fully use it, I would say, so that you can fully assess it and critically appraise it and make sure you're happy with it. But effectively, we're able to identify a low-risk group where their subsequent stroke risk is at 7 days is less than 1%, a medium risk group where it's 1 to 5%, and a high risk group where it's over 5%. And then basically locally, you'll be able to determine what are the appropriate actions at each of those risk levels. And when we compared it to the ABCD2 and the ABCD2 and 2I, and it certainly has outperformed them. Now, since we haven't published it yet, I don't expect you to necessarily run out and use it, but I would sort of take some common themes of all the tools that are available and certainly say for right now, certainly looking at patients where there's motor deficits or speech deficits, and they're lasting minutes to hours without a clear stroke mimic. So that's the patient that comes in with isolated vertigo, bilateral symptoms, or isolated confusion. Those patients are at elevated risk, and I'd advocate managing them more aggressively than you would with patients who don't fit that profile.
All right. So yeah, those motor deficits, I mean, we know when we see them, those real TIAs, those are the ones that we need to be worried about. And that always brings up the question. So those ones that we are really worried about, which of those patients require a CT angiogram of the head and neck in the emergency department? Because my understanding is that a CT angiogram of the head and neck, the sooner it's done, the better, because then the sooner the endarterectomy is done, which is really the only thing that has been shown to really improve patient outcomes significantly, is that endarterectomy for those patients who do have the criteria on CTA. Should we be CTAing every patient who we think might have a TIA in the emergency department? What about the rural physicians who can't get access to it quickly? If you're in a big center and you can get access, should we be doing everyone? Should we just be doing the high risk patients? It's actually quite confusing.
Yeah, and there isn't a whole lot of evidence that guides who we should image. We do know that if somebody has a hot carotid, so basically where they've got greater than 50% stenosis, but less than 99% or less, so not a complete occlusion, but anywhere below a complete occlusion, these patients need to be get their endarterectomy or carotid revascularization to happen quickly, ideally within hours to days, and definitely within 2 weeks at the outside to basically make a difference. So we know those patients need this done. Now, who are those patients can be? Well, this can be an anterior circulation event. It's likely going to be a big event. So certainly the group that I was just speaking about, those high risk motor, and especially where it's motor in arm, basically leg, arm, and face, speech deficits, those patients are going to be a much higher risk. And again, it should be minutes to hours, not fleeting seconds, should not be bilateral. So those patients, yeah, we probably should certainly try to endeavor to get them imaged if we can. Certainly if you have the technology available, I would advocate in those patients it should be done sooner rather than later. But patients with lesser symptoms can probably wait. Certainly, and certainly many places have systems where they have outpatient Dopplers that can be done the next day or a couple of days later. And that can be appropriate as long as they're interpreted right away and acted upon if they're showing a hot carotid. If you don't have imaging capacity and you do get a really high risk patient, that patient probably should be considered for being transferred out to get looked at. Certainly if they're sort of showing complete arm, face, leg with symptoms lasting for a significant period of time, and they haven't been recently imaged to their neck, that patient probably should be sent out to be managed, but there isn't clear evidence on this.
All right. So that's a bit about the CTA who needs it soon, or at least a Doppler with sort of within 24 hours, or a very good system to get your patients imaged relatively quickly. The rage in terms of treatment is dual antiplatelet therapy. And I've heard mixed things in terms of how good the evidence is. In your opinion, which patients should we start on dual antiplatelet therapy from the emergency department who we suspect have a TIA?
Yeah, so there's been quite a lot of new evidence on this. The CHANCE study out of China looked at 21 days, dual antiplatelets, high risk TIA, so ABCD2 4 or more was what they used. And they treated patients for 21 days. They found a absolute risk reduction of 3.5%, but it was only in a Chinese population. The baseline event rates were about what we had prior to year 2000, not our contemporary baseline rates. So different patient population. More recently, the POINT study came out, and this was a predominantly North American and European study, and it enrolled nearly 5,000 patients. They only found about a 1.5% absolute risk reduction. So from 6.5 down to 5% for their composite outcome of major ischemic vascular events. So ischemic stroke, myocardial infarction, or vascular death. But they also found an increase in hemorrhagic stroke, which went from 0.4 up to 0.9, so an absolute risk increase of 0.5%. So their treatment comprised of a 90-day treatment and a 90-day outcome versus the CHANCE study in China that looked at 21 days. And they looked at the time to event analysis. And what they found is that there was early separation as far as the ischemic events and subsequent ischemic events, and that this maximal separation happened by 21 days. And they found that most of the hemorrhages happened late, i.e. after 21 days. So many people have sort of extrapolated that data and combined it with the CHANCE to say 21 days in a high-risk patient, ABCD2 score greater than 4, or if you're using the Canadian TIA score, somebody with probably a medium or high-risk group should be managed with a dual antiplatelets for 21 days. But that being said, there is still a knowledge gap in the evidence, because this study was not designed to assess people at 21 days. It was designed to find them at 90 days. And its results positive, but not nearly as positive as the CHANCE study in China found before. 21 days is probably the right answer, but again, there is a bit of paucity of evidence to say definitively that that's the answer.
All right, so those really high-risk patients, motor deficit, speech deficit, there probably is good enough evidence there as long as they don't have any high-risk bleeding problems to start them on dual antiplatelet therapy, but definitely for no more than 3 weeks, have them follow up quickly. Great. Well, thank you so much. Thank you so much, Dr. Perry. And thanks to Dr. Yan, Dr. Murray, Dr. Perry, Dr. Kovacs, and Dr. Ole for all their insights. I hope you all can take a few clinical pearls away from this CJEM EM Cases collaboration on the Best of the Just for Facts article. We're going to open the floor to a few questions in a moment, but please do complete the evaluation, which will be posted on the chat so that CAEP can continue to bring great content through these National Grand Round presentations. Attendance certificates for the CME points will be sent out to everyone. I just got to say that it really is wonderful to see researchers and educators collaborate to help improve EM practice in this great country of ours. Let's continue to break down those silos that exist in our specialty and work together for a better future. I'm going to sign off now, and we'll have a few questions, and then we're going to pass the baton on to CAEP's current past president, Alex Chochinov, for a special announcement that you definitely don't want to miss. So until next time, stay safe and take it easy. We're all in this together. Take care.
Thank you, Anton. So the questions that we have that were remaining for the speakers, if I could perhaps go through those, if everybody's up for a few questions. So we'll get you all maybe to turn your cameras on, and we'll go through those. So first of all, thanks again for contributing to the CJEM Just the Facts series. which has been really successful in highlighting key facts for Canadian emergency physicians. So we have a question here that's for Justin. So Justin, your question relates to DKA, perhaps the milder cases. Is there any role for aggressive early management and then discharge from the emergency department without consulting or admitting these patients?
I think there absolutely is a role for that. It's one of those things where DKA, when it is mild, can be managed by us as emergency physicians, and we can see fairly quick resolution of acidosis and ketonemia, as well as the hyperglycemia, with good fluid resuscitation and insulin management. And I think as emergency physicians, we do feel the pressure of having to try to, treat them and street them, so to speak, right? So I think it is certainly something that is within our realm to be able to treat for those milder cases. I think the important thing, though, is to make sure that our patients have really good discharge instructions. Same as with anything, right? Great discharge instructions, really good follow-up in case of recurrence, because there is a fair bit of evidence, and we've done some work looking at recurrent visits for hyperglycemia as well, and patients can come in after discharge with recurrent episodes. So I certainly agree that there is a role for us to play in that.
And while we have you up front there, Justin, one other question from the audience related to the use of Ringer's lactate or balanced fluids versus saline. Do you have any thoughts on that?
Yeah, really great question, and this is very timely, and I just want to make a shout out to Rob Oley, my colleague here, who brought this article to my attention that was just tweeted a couple days ago in I think it was, what was it, JAMA Network Open. Anyway, so there's an article that was actually part of the SALTED and SMART studies that were run by Wesley Self. Where they did a subgroup analysis specifically looking at DKA patients and choice of Ringer's lactate versus normal saline. And, there are some limitations to their study where, it is a subgroup analysis and single center and so on and so forth. But this study that they published looks specifically at comparing resolution of DKA for this patient population. And there was some suggestion anyway. Again, things are early and it is a small sample size, but there is some suggestion that it's possible that isotonic fluid solution like Ringer's may be preferable over saline for faster resolution. But I think the verdict is still out, and there needs to be some high quality RCTs on this topic.
Excellent, thank you. But perhaps the term normal will be removed from saline at some point soon. I have a question now from the audience for Dr. Perry, for Jeff. So the concern that you raised for the high-risk TIA patients we would all share, and the aggressive workup and investigation. Is there, however, anything that needs to be done urgently for the mild or moderate cases, Jeff, that we should be aware of?
Well, certainly, in addition to taking a good history and exam, I think certainly an ECG is important. That is something that we can manage if it is AFib causing, and they can present in multiple ways if they have a cardioembolic cause. So getting an ECG is important. Also getting a glucose for Justin to certainly stroke mimics. Hypoglycemia or even hyperglycemia can present as a stroke mimic. So doing those. CT head, if you're really thinking that this is a TIA or a stroke, they should get a CT head. If their symptoms have all gone and they've completely gone back to baseline, there isn't any strong evidence that I'm aware of that says you have to do it immediately. So if you don't have a CT scanner available at night, or you have to ship them out somewhere, it's probably not necessary to sort of risk people's lives sort of racing down a highway in the middle of the night, hitting a moose. You can kind of probably hold off till daytime hours and get that done at a slower pace.
Okay, thank you. And Jeff, just a couple of other quick clarifications that people have asked for. If there is access to MRI, does it offer any advantage in these patients, in TIA patients, high-risk TIA, over a CTA?
So Probably not a whole lot as far as the neck imaging. The CTA is extremely good at detecting significant stenosis, and there's some, it may even be in some circumstances better than MRA. So it is very good, and it's quick. So I would say it probably isn't a big advantage with that regard. The advantage with MRI would be actually looking to get a better diagnosis. Is there actually an acute infarct present? That will, if there is an acute infarct, that basically gets rid of the issue of the stroke mimic. And you're dealing with somebody with a cerebral ischemia, and so that your management probably would be triaged somewhat differently based on that information.
Thank you so much. Well, look, thank you all very much. There was, we're about to just head over now for a very important announcement. And I imagine that perhaps during this, we will find out where to get these wonderful T-shirts that George is promoting across the country to sum up the ethos of Canadian emergency physicians. I want to thank all our presenters this evening. It was a wonderful panel. Thank you to Anton. Thank you to all the presenters. I am now going to hand over to our president, Alex, who is an announcement to make. Alex, over to you.
Thank you so much, Paul and Anton as well. Just make sure that I'm all connected here. Thank you for calling me president. I'm way past being president, but this is my last presidential duty. And it's a really important one. And I'm really honored to present the President's Award, which was decided during my tenure. So I get the honor. Most of you know already that the President's Award is CAEP's highest honor. It recognizes a member who's demonstrated outstanding contributions to CAEP as an organization and to our specialty as well. So Dr. George Kovac, as you heard today, is a very accomplished academic and is part of a group of very accomplished academics affiliated with Dalhousie University. He's been a longtime educator. He's been an advocate for CAEP's work. And he's particularly known for his work in the realm of resuscitation and airway management. It was probably 20 years ago now, George, that you and your group recognized the inadequacy of ACLS training and ATLS in airway management. And I also know that you really understood from your practice in rural Nova Scotia the fear that so many physicians feel in the setting of critical airway management. George, in partnership with CAEP, founded and developed a case-based, hands-on, skill-focused airway management roadshow. The long name is Airway Interventions and Management in Emergencies, but we all know it as the AIM roadshow. It was targeted to community physicians, but it's been applicable to all emergency physicians, from small rural hospitals to big inner-city tertiary hospitals. This program, since it was launched in 2000, has trained over 8,000 physicians in airway management. That is phenomenal. And, I think I was one of the first to take it. It was in Banff. I don't know, George, whether that was your first show, but it was pretty early on. I was a tertiary physician at the time, but, no physician in a big or small hospital ever feels completely comfortable with airway management, and I loved it. My experience isn't as interesting as the experience I'm going to tell you about from a rural physician 16 years later. This is a generalist from La Loche, Saskatchewan, who reached out to CAEP in 2016 in the aftermath of a horrific mass shooting in La Loche. La Loche is a small town. It's got a population of about 2,800, or did in 2016. This physician had gone to Montreal to take the AIM course 1 month prior to the shooting. And he resuscitated his patients in their health center. And he asked CAEP to pass along a message to George. The message was that he had saved at least one patient's life during this mass casualty event. This is a patient with bilateral sucking chest wounds and a very difficult airway. And the story is, it actually was quite a moving letter. It's just one of many, and I'm sure that there are many other such stories. most of which are untold, from doctors all over Canada, amongst that 8,000. In 2018, George became one of only 3 emergency physician representatives to be invited to be part of a Canadian multi-medical disciplinary airway focus group, and now is on an international airway guideline writing group called Project for Universal Management of Airways, with the cool acronym of PUMA. His work, this particular international endeavor, is a significant achievement for both CAEP and really puts emergency medicine in Canada on the map. I'm not going to take all your time this evening going over the litany of his accomplishments, but I just want to mention one other one specifically, and that's his leadership as a medical director of a clinical cadaver program at Dalhousie. This is really an amazing program, one which we've adopted to some extent in Manitoba. The cadaver program gives unparalleled physical fidelity in working with these cadavers, and has really transformed the way emergency procedural training can be delivered. It's used in the AIM Advanced course given twice yearly in Halifax, and as I mentioned, it's now been adopted in centers across the country for various educational purposes. So that's just a fraction of George's sustained record of research, education, and innovation in the field of airway management. He has advanced the practice of our beloved specialty of emergency medicine nationally and internationally. And so it is my pleasure and honor to virtually present CAEP's President's Award to Dr. George Kovach. Over to you, George, and I hope you have a few words for us.
Thank you. I hope we don't mind. I'm drinking a beer called Hunky Dory. I'll hold this up as a award reception. But thank you for those kind words. I am going to refer to my notes because it's about 7 or 8 pages long, and after the 3rd or 4th page, I tend to forget stuff. But first, I need to thank you, Alex, and CAEP. And I feel honored to be nominated, and I really had no clue that I was being nominated until I heard a couple of weeks ago about the award. But I want to go back, and I'm going to go back to the late 1990s when we had this idea, and the idea was born out of fear, a fear that I had and I knew others shared. And I sat down with some of us who know and love, Tim Allen at the time, and Vera Klein was involved, and some other people that now have a lot of gray hair: John Ross, Doug Sinclair, Sam Campbell, and Dave Petrie, to just name a few of the old timers. But one of the greatest collaborations that was been extraordinarily important for me was my relationship with Adam Law, who's my academic partner over the time. And Adam is a anesthetist, but before he became an anesthetist, he worked in rural New Brunswick, and we shared this common interest, and we've been collaborating ever since in terms of academic endeavors and with CAEP. But I want to take you back to a moment in the mid 90s when we had written a paper together, myself and one of my heroes, Pat Crosscarry, and it was rejected a couple times, and that's not the only story of rejection I've had over the years. Ultimately, it was published in Academic Emergency Medicine in, I think, 1999. And it was called Clinical Decision Making in Emergency Medicine Perspective. And it's probably the paper I'm most proud of over the years that we wrote together. And we talked about many things, but one of the things was, at that time, we said emergency medicine is about 2 things. It's about acuity and prevalence. It's about, we have to manage what's common and what comes in, and then we have to manage what's not so common that has the potential for bad things happening. And this is also a time when waiting rooms were actually rooms, small rooms. And what we've known over time is that things have changed significantly, and there's this new dimension that has come upon us, and that we all know about, and it's that third layer. So you've got acuity, you've got prevalence, and you have complexity, and much of the complexity that we're being faced with has been beyond our control. And it's an issue, for example, is overcrowding. And that's much too simple a term to capture complexity, but it's the one I'm going to use here. And so in managing this type of complexity, unfortunately, the reality is we have less time with patients. And I'm going to say this perhaps provocatively, has the potential to threaten our comfort, experience, and even quality of acute care. And in fact, in many regions around the world, emergency medicine is having their acute care autonomy being threatened, particularly with COVID, and that's just not in other continents. That's happening here in this continent, and I would say also here in this country. And this is a part of this has been brought up because of the additional complexity of the pandemic. Yet in some regions, and I'm sure many others that I'm not aware of, parts of BC, I know in London, Ontario, and Kingston, and the Maritimes, to just name a few, have really been able to again break down the silos and collaborate as equals with our critical care and anesthesia colleagues, as opposed to some emerging turf wars that we haven't seen in quite a long time. And there are many challenges in ensuring that we're what I feel that we need to be, as part of what I said earlier. We need to be better than good for high acuity, low opportunity, or halo events, right? We are going to get the experience with things that are common. We have to have the educational support for that material, right? There's no question about that. And people make that argument saying, well, listen, we don't really see that many X, Y, or Z, so we should direct our attention to the things that are very common. But I'm going to argue that you have to do the opposite in some ways. You have to direct your attention to these things that don't happen very often. And you have to do that for the sake of patient safety, for your colleagues and your team's safety, and your own safety. And that can be a real challenge to do. And again, I think it's through the work with organizations like CAEP that we're able to manage this and bridge this gap. But it is going to be a challenge into the future. Many of you might know is that I take offense somewhat to the term resuscitationist, and it almost in some way again supports what I'm saying, is that people have to use that word outside of their discipline to say that they're resuscitationists, and there is born hence the T-shirt, emergency physician I resuscitate. And I know there are challenges in terms of small places and larger places. How do you provide this experience for people practicing? We can do it, and there are ways around it, but it is going to be a challenge. Now I'm gonna switch gears to finish off and say that Wednesday evenings are as close as I get to a religious time for me, because it's when I get to play hockey with Dave Petrie as my center, and against a South African defenseman named Sam Campbell. And I miss them tonight, but for good reason, to spend time here with my colleagues. But I want to finish with this. When I was trying to think of something to capture what was important here, something came to me, and it relates to 2 weekends ago. I'm involved with a group chat with 3 young colleagues, Nick Sowers, James Gould, and Adam Harris. And I jumped in a conversation that they were having while I was working in the woods at my cottage in the middle of the province. And I was in the woods with the South African again, Sam Campbell, my eldest son, Ben, and then Miles, who I refer to as, he's the local, who I refer to him as my big brother. And so there was 4 of us operating chainsaws and working with my tractor. as we took out in a few days about 40 ton of, cut down about 40 ton and pulled out 40 ton of hemlock. And unfortunately, these hemlock are being devastated by a pandemic affecting these beautiful trees. And I love being in that setting, but after that day of being with my friends and family, I was getting a little bit philosophical, and I jumped into the conversation that was happening with my young colleagues. And I'm going to read this to you, and I'm going to close with this. But before I do, I'd be remiss not to thank my most of the time adult children, Hannah, Maya, Ben, and Aaron. And I was thinking about this earlier. It's been 40 years since I met my love of my life, Sandy, who's been by my side ever since. She's down at the cottage right now, but without them, I am nothing. So here I am. I'm going to finish this, and I'm going to read here what I wrote in this text. Feeling philosophical. It's been a rough year with personal and family health issues, scares, challenges, and COVID too. For me, the burden of COVID was the upload of materials that was being used locally, nationally, and elsewhere. I was nauseated about the consequences of being wrong. I'm at my best in the woods, where, in contrast to what I preach, is a place where I learn on the fly. I'm looking forward to watch and help you guys develop your careers. I still wake up 9 of 10 days feeling privileged to look after patients, whatever they present with. We are drawn to be better at what scares and excites us, and we will reclaim the resus priority. But always remember the privilege of making a difference for all types of patients, whether you cannulate them, intubate them, or just listen to their story. Thank you for this honor.
Thanks, George. That was great. I don't see Anton, so I'm going to respond to you and just thank you for not only what you've done over these past many decades as a physician, but for taking the opportunity to show us a little bit about yourself and your context, your family, and the people you work with. Just for taking the time, because we don't often get these this time at in-person conferences. It's one of the benefits of these virtual sessions that we learn just a little bit more about people like you. I'm still wrestling with the notion of Dave Petrie as a hockey player, but other than that, really?
No, he's a power forward.
He is powerful.
Yeah.
Anyway, congratulations on behalf of all of us who've tuned in, on behalf of all the emergency physicians in Canada that you've helped. Thanks to all our presenters tonight, to Anton for moderating, and for all of you for tuning in. These sessions are great. I learn a lot, and I connect even more. So thanks very much, everybody.
Thank you.